Good afternoon, everyone. Welcome to the Department of Medicine PG lecture series. Today we have Dr. Avanish from our Department of Rheumatology, who is an associate professor there, who is going to give us a lecture on overview of mixed connective tissue disorder and undifferentiated connective tissue disorder. So we welcome you, Dr. Avanish.
Thank you. So good afternoon, everyone. So my topic is mixed connective tissue disorder and undifferentiated connective tissue disorder. These terms are very loosely used in normal practice, and the aim of this lecture is to get you to understand when exactly to use these terms and also how to manage this condition. So the evolution of concept, we would discuss the MCTD, what it was initially thought of and now what it is, what are the criteria for MCTD, what are the clinical manifestations, the nail fold changes, the antibodies, the pathogenesis, the treatment, what do we do, and what's the prognosis. Also, I would like to give you a brief on Uctd concept and how it is matched. So actually in 1972, the first time mixed connective tissue disorder word came up. And this was introduced by Dr. Sharp. He is, if you know him, he is a person who had given the first criteria. It's called the Sharp's criteria for mixed connective tissue disorder. So they actually describe about 25 patients of MCTD who had a specific antibody against RNP. So they found that these people have high specificity and strong affinity antibodies against RNP. So what is RNP? RNP is basically a molecule which binds RNA. So it's a protein binding the RNA. So this was detected by hemagglutination method, and they found that these patients were also having strong ANA speckled pattern on the ANA when they looked at it. So they also, the specific thing that they found in these patients was their anti-dsDNA was either negative or very low titer positive, and these patients had normal complement levels usually. So this historical description is about 40 years old, and the concept that time what was presented by Sharp was these patients are RNP positive, they have Raynaud's phenomena, they have swollen fingers, esophageal dysfunction, and some mild symptoms basically. So they do not have renal disease, they don't have lung disease, they only need steroids, and that also low dose steroids, not the high dose steroids of lupus and the steroid sparing agents that were being used. So according to them, this was a milder form of CTD which was being detected with RNP positivity, and prognosis was generally good. However, over the last 40 years, we have found that they actually don't have, not all MCTDs are mild. Actually, a lot of them have lung involvement, muscle involvement, renal involvement, and the steroid requirement actually is quite high in almost half of these patients. And they would require immunosuppressions, as well as their prognosis is somewhat closer to lupus than initially thought of. So this is the concept of MCTD, Uctd, and overlap. If you understand what I am trying to say here is, so mixed connective tissue disorder here on the right, what you're seeing has combination features of lupus, systemic sclerosis, and polymyositis. Initially, it was described like that. Now even RA. So these are basically 4 diseases, and their features of overlap are seen between these diseases, and MCTD is a concept which floats around between these 4 diseases. Not necessarily every patient will have all the 4 features. You may have features from any 2 diseases rather than 4. So based on that, some criteria have come that I'll come to. What do you mean by overlap syndrome is also important to understand. What is overlap and what is overlap syndrome? Overlap syndromes are basically generally described syndromes where, for example, systemic sclerosis, myositis overlap syndrome is well described. So that is a syndrome. While overlap can happen, mild overlaps can happen between diseases. So when do we call something as overlap? It should fulfill the criteria of the first disease and the second disease at the same time. So for example, this in the center is showing you a PM and systemic sclerosis, polymyositis, systemic sclerosis overlap. So this patient who are here are having clinically, they are features of both, and also they may fulfill criteria for Bohan and Peter as well as for the ACR criteria for systemic sclerosis. So these are the defined overlap syndromes. While this undifferentiated connective tissue disorder are diseases where you have some serological evidence, some clinical evidence, but not enough to diagnose them as a particular disease. We'll talk about it in detail later. So these initially the first criteria which has been given by Sharp himself was the Sharp's criteria in 1987, and this criteria suffers from lack of both sensitivity and specificity. It's as low as 40% sensitive and not even specific. However, the most talked about criteria which you should know is Alarcon-Segovia criteria. Alarcon-Segovia criteria is supposed to have the best combination of sensitivity and specificity. So what it tells is you have a very high RNP titer, more than 1:1000, and then you have clinical features which have to have 3 features. At least one of them should be myositis or synovitis. So out of these 5 features of edema of hand, synovitis, myositis, Raynaud's, and atherosclerosis, you need to have at least 3, out of which one has to be muscle involvement or joint arthritis, not just arthralgia. So this is the criteria which is mostly followed, while these are the other criteria, Sharp criteria, which is not the best. And this, the Kusukawa criteria, is supposed to be one of the most sensitive criteria. So this criteria, you need to have at least one of the 2 common features, which is Raynaud's or swollen fingers or hand, and then you have antibody positivity, and then you have features from at least 2 out of the 3 syndromes, that is SLE-like syndrome, systemic sclerosis-like syndrome, and the third one being polymyositis-like syndrome. So if you notice, their RA is not mentioned in this. Actually, RA has come into picture later when people realize they are deforming arthritis with mixed connective tissue disorder. But when Kusukawa came with this idea, he had 2 out of these 3 plus one common feature with the antibody positivity. This is the most sensitive criteria, while Alarcon-Segovia has best balance of both. So both of all these criteria have actually already been compared. As I told you, Alarcon-Segovia criteria is 73% sensitive and 86.2% specific in one of the validation cohorts, while Sharp criteria had the lowest specificity as well as the sensitivity was only 42%. The point prevalence, however, does not change which criteria you use. You will miss some patients, you'll gain some patients. So overall, this is the newest criteria which has come. You don't need to you don't need to mug this up, because this criteria is online one when you want to use. And secondly, Japanese criteria is not yet accepted by the scientific community internationally. But this is the criteria which, according to them, has the highest sensitivity, which is 90%, and specificity of 98%. So basically what they have done is almost similar to the Kusukawa criteria, but they have added one characteristic organ involvement. If you see, Raynaud's, puffy fingers or swollen hands is the same, antibody is the same. This third part is the new addition, where you have characteristic organ involvement which are very specific for Mctd, like pulmonary hypertension, aseptic meningitis, and trigeminal neuropathy. Rest all is the same. So coming after the classification criteria or the diagnostic criteria, the point prevalence of Mctd actually in India is not known. What we have is data from Europe as well as from US. So a point prevalence is around 3.8 per lakh. So it is actually similar to what data has shown in India. Actually, a lupus prevalence was calculated. Only one study in 1993 has been done by Malviya et al. From Delhi, and they had a point prevalence of about 3.2 per lakh of SLE actually. So it is actually similar to SLE, but actually probably the SLE prevalence in that study, of very old study, is underestimated. So what world over we know is prevalence of SLE is around 15 to 60 per lakh. And Mctd is only 3.8. So actually Mctd is much rarer than SLE, as you will know in your clinical practice, that you see less often Mctd than SLE. But we don't have any data from India. Mostly these are again women. As you can see, almost 3 to 4:1 ratio. Lupus is even more female predominant, 9:1. Here it's 3 or 4:1. And the age varying between 35 to 48 in these cohorts. But remember, these cohorts are all from outside. They are Caucasians mostly. We see much younger patients than them actually with Mctd. So what are the clinical features usually mixed connective tissue presents with? Features of pulmonary hypertension, esophageal involvement, musculoskeletal, cardiovascular, renal, and then Raynaud's, and along with its changes on the capillaroscopy that we see. So let's discuss one by one each of them. So pulmonary hypertension, actually initially it was thought to be 10 to 50% of patients of mixed connective tissue were thought to have pulmonary hypertension. However, it has varied a lot. Recent studies are from 3.5% to almost 18%. Why is there so much difference? This may be because of the feature, how you are defining pulmonary hypertension. It depends on that. So one study actually took patients only when they were referred to the clinical tertiary care center. So obviously they will have enriched population, while the other one is a national registry where the population, obviously prevalence of pulmonary hypertension much lower. Also, how you describe, how will you screen them? Are you screening them by using a right heart catheterization? And what is the cutoff you are taking? So now actually one study has taken as pulmonary arterial systolic pressure as more than 40, and the other one has taken right ventricular systolic pressure as more than 25. Actually, ideal world, if there is no obstruction between the pulmonary artery and the right pulmonary artery and the lung, the both should have been equal. So actually none of these both are the criteria. What actual criteria has is the mean pulmonary arterial pressure based on right heart catheterization more than 20. It has changed from 25 to 20 a few years back. So these studies are all faulty, and so the actual prevalence is still not known, but prevalence is not as high as 50% probably initially estimated as. So what are the features which are associated with pulmonary hypertension? So anti-UNRNP positivity, obviously that's the part of this thing, but its titer also correlates probably. An anti-endothelial cell antibody, which we don't routinely check, but in research setting it has been found. And also anti-phospholipid antibodies like ACL and IgG beta-2 glycoprotein 1. So all these have been associated with development of pulmonary hypertension. Endothelial antibody was associated with a high level of thrombomodulin and von Willebrand factor in some study, and was associated with pH. Also, if you have Raynaud's phenomena and abnormal need full capillaroscopy, on capillaroscopy, if you find some dropouts, if you find abnormal megacapillaries, probably they are associated again with pulmonary hypertension, but not ILD. The poor prognosis, it's one of the pulmonary hypertension is one of the poor prognostic markers with MCTD patients. So they need to be treated aggressively. So cardiovascular involvement, it is also described in 13 to 65% of patients, and pericarditis is the most common feature as in other CTDs also. And but diastolic dysfunction and accelerated atherosclerosis have also been described. So it increases CVD risk, this disease as such. So ILD, the interstitial lung disease, has around half of the patients with MCTD will have significant ILD. But if you go by HRCT, almost 80% of them will have. Same like systemic sclerosis, similar to systemic sclerosis. Systemic sclerosis, if you do CT for everyone, you will find 90% of your patient will have some form of ILD. They may be early, they may not be symptomatic, but around 45 to 50% are symptomatic and active ILD. Almost 20% of these patients will have severe fibrosis, poor functional status, and mortality, and with very short duration of illness, like a rapidly progressing ILD. So what is the commonest pattern in ILD? Non-specific interstitial pneumonitis is the commonest pattern, followed by the UIP and LIP. This is true for most CTDs except rheumatoid arthritis. All other CTDs will have NSIP pattern as the most common pattern. So anti-UNRP may contribute to manifestations, but it's not proven. And reduced DLCO is the most sensitive marker to predict that somebody is going to get an ILD. So these are the patterns I'm showing you. So this pattern is the UIP pattern. If you see that there are more of honeycombing and less of ground glassing, and this is a lot of traction bronchiectasis. Well, it's the NSIP pattern where you see more of ground glasses and you see less of cysts and bronchiectasis. And then on the far right is your LIP pattern. This LIP pattern has these cysts and our septal wall septal thickening and peribronchial thickening will be seen with some nodules also. So this is the most common pattern, followed by UIP and LIP. LIP is a pattern which is most specifically seen in Sjogren's actually, but you should know these patterns for understanding. So actually, there was a cluster analysis on the 200 odd patients from Norway, which was published in past. And in that, they found MCTD patients had 3 different subgroups. The first subgroup was the vascular phenotype, where they had antibodies against endothelium, antibodies against antiphospholipid antibodies basically, and they had more of vascular features like pulmonary hypertension, Raynaud, lipidoid rash, as well as vascular thrombosis. The second group is the group where almost more than 98% had lung disease. These people had esophageal mortality and myositis. While the third group was the severe aggressive arthritis, where the anti-CCP antibodies were positive and they were more of an RA phenotype. So this subgroup 2 is the one where you should be looking for more of aggressive lung management. So esophageal involvement, if you know that systemic sclerosis as such has a lot of esophageal involvement, almost 85 to 90% of systemic sclerosis have esophageal dysmotility. And similar to that, MCTD almost little lesser though, but 64% of the patient had been described to have esophageal dysfunction, with almost 50% of them having an abnormal acid reflux. However, it was the esophageal dilatation and dysfunction which was associated with development of lung disease, ILD, rather than the pH. So it tells you it's the micro aspirations probably happening with this disease, which may also be contributing to the development of lung disease. So it is important to give therapy for prokinetic agents to prevent reflux, to do physical measures to prevent reflux. So you can see this is a CT cut where a normal esophagus should be just about visible or not visible, but this patulous esophagus, which air fluid level is suggestive that there is a dilated esophagus, and which can be picked up easily on an HRCT, which is done for every patient with systemic sclerosis or MCTD, has to have an HRCT at baseline, and that will pick it up, even if the patient may not be symptomatic. Musculoskeletal disease, almost 75 to 95% of patients of MCTD will have musculoskeletal involvement and arthritic involvement. But 50% of them will have erosive arthritis. What do I mean by erosive arthritis is, if you look into your right of these images, so these are the marginal erosions. So at the bare area of the basically joint, so joint surface, if you have an erosion here, that is more suggestive of osteoarthritis. But if you have it more on the sides, which is because of a pannus, which is from the synovium growing and eroding into the bones, it is more suggestive of an erosive arthritis like an RA. So almost 50% of the patients will have features like RA, and they will have association with HLA-DR4, which is the haplotype associated with rheumatoid arthritis, while SLE and other diseases are HLA-DR3 and DR2. So this is more so like rheumatoid arthritis genetics wise. Although rheumatoid factor may be positive, you should not call these patients rheumatoid arthritis, even though they may have RF high titer positive. Anti-CCP is, however, lesser, with only 9%. Even if this anti-CCP positive, if they have esophageal dilatation, if they have Raynaud's phenomena, if they have ILD, they should not be considered RA, but rather an MCTD. So next is the muscular involvement. Almost 2/3 of the patients with MCTD will have overt myositis, which may range from mild to severe. In general, what we has been taught in medicine on rheumatology is the prime polymyositis or dermatomyositis are the ones which are severe myositis, while overlap myositis are usually mild, but it may not be true all the time. And especially in MCTD, patients can have actually a very severe myositis where they may be bed bound, but it varies. So if you look at this antibody, anti-RNP, where compared to those without, so out of myositis patients, if you compare those which are RNP positive and those which are negative, means they are either positive for some other antibody or not positive for any antibody, the RNP ones generally respond better to steroids, and that is the truth. So it is little easier to treat these patients, but they may be severe. So if you do a biopsy will be similar to a dermatomyositis, which is the infiltrates will be mostly perivascular, perimycial, but not endomycial, and also the cell types will be mostly CD4 positive, and MAC expression is not as much as it is in the polymyositis, where it is on the sarcolemmal surface. So if you look at this, it will be more like dermatomyositis. Renal involvement is something which was classically initially thought that there is no renal involvement in mixed connective tissue disorder, but almost 5 to 36% of patients in different studies have renal involvement. But you should remember, the renal involvement usually not proliferative. So it will be mostly proteinuria, which is there, and some mild cells may be there. But usually glomerular hematuria, hypertension, we do not see in MCTD. Usually what we see is a membranous glomerulonephritis, which we will pick up on a biopsy. 72% of nephropathy patients experience resolution or treatment on improvement with steroids itself, and anti-urine ANP seemed to have no correlation as such with nephropathy. Raynaud's phenomena, this is one of the features which almost always have to be there. So that there are two diseases that if your diagnosis is systemic sclerosis or MCTD, and if you are not having overt Raynaud's, either clinically or historically, then you should question yourself whether your diagnosis is really correct. Because Raynaud's is something which is present in almost 90 to 95% of patients with systemic sclerosis and almost 90% of patients with MCTD. So Raynaud's tends to be less severe in MCTD. Severity means we mean to say gangrene, we mean to say ulcers non-healing. They are lesser in MCTD usually, with loss of digits being lesser. And this anti-RNP may actually be associated with the vasculopathy which these patients have. So I'm not going into the details why Raynaud's happen, but generally it's the endothelium which is damaged and not responding to nitric oxide, not responding to usual vasodilatory basically molecules which are being released. So they are mostly, they get constricted easily and they get thrombosed easily, and that's why you get bad Raynaud's. So capillaroscopy actually can pick up these different patterns of involvement and can give you an idea on what is happening in the lung, because the finger capillaries, whatever is happening, similar things will be happening inside your lungs, and that's why it corresponds to the pulmonary hypertension development. So usually scleroderma has early active and late pattern. Sometimes we just say slow and active pattern. So MCTD usually has a slow pattern of scleroderma if you look at the capillaroscopy, which is irregularly enlarged or giant loops with not much of capillary loss. Once capillary loss has happened, it means that it's already damaged vessels and not much activity is happening. So it is usually the earlier stage of scleroderma changes that you see, but it's not present in all patients, and you should not exclude patients based on capillaroscopy that they don't have MCTD. They have only 30% of these patients will have similar this feature. So this is what I mean. This is a normal parallelly arranged capillaries which you see at the nail fold. Early changes will have these giant capillaries which are big, and there may be some hemorrhages. In active phase, basically more of hemorrhages, little bit of capillary loss has started, and in late stage you have this neoangiogenesis, arborization and all, and very less capillaries. So in this MCTD patient, we see more of these early type of disease mostly, and this actually there is a also there may be little bit of density loss, but not like as bad as the late one. So this actually there's a study from our center. An MCTD patient with scleroderma pattern was associated mortality, and also the capillary density was lower in patients with MCTD as compared to patients with RNP positive lupus or RNP negative and RNP negative lupus. And if you see, it's the lowest in MCTD by 5.1 as compared to RNP positive lupus, which is almost similar, 5.1, which is 7.25, and those with RNP negative SLE, which is around 9. Let me tell you, 10 is considered normal, 7 to 10 is mild reduction, 4 to 7 is moderate, and less than 4 is severe reduction in capillary density. So serology, RNP positivity is the hallmark of this disease. What is RNP? So U1 SNRNP is composed of U1 RNA there is an RNA, and then there are some SM proteins, which are common 7 proteins which are wrapped around them, and three U1 specific proteins, which is U170 kilodalton protein, U1A and U1C. So it is the U1 70K against which the antibodies are produced in Mctd, and this is the most specific thing which you can look at. If you have the capacity to do that, then it is actually, this is the antibody, not the whole complex. So this is a spliceosome complex. Let me remind you that it works with splicing and mRNA. So it was present in 75 to 90% Mctd patients were having antibody against this component, and only RNA component was only in 38%. So it's not the more specific one, it's the 70K. Okay, but UNRNP is not specific to Mctd. If you look at lupus and just do a RNP, even if they have no other features of Mctd, if you do, almost 40% of them will come positive. So don't make your diagnosis of Mctd based on antibodies. Antibodies are always an additional thing that you look at. It's not the primary thing. Your diagnosis should be clinical based on what are the features rather than what antibodies are positive. So just because somebody is RNP positive, no Mctd, just because SSA is positive, you can't say secondary Sjogren's. You need to have symptoms for that. SSA will be positive in 20% or 30% of patients with lupus. So in a study of 161 patients, as I told you, that is the thing. And you can have it even in systemic sclerosis and myositis. So IgM anti-SNRNP titers were significantly higher in SLE than Mctd. It was the IgG type which is more seen in Mctd, but we don't have the features to do this, and it doesn't really matter. At the end of the day, it's the clinical features. I think I'll skip this. Okay. To propose mechanism of this antibody causing disease is it binds to endothelium, causes endothelial cell activation and damage, and that leads to the vascular phenotype which is seen in Mctd, pulmonary hypertension, Raynaud's phenomena, thrombosis, all these things, and also a risk of CVD. While immune complex related complement activation and deposition causes things like myositis, which is similar to dermatomyositis, where you have complement deposition around the vessels, and it's mostly vasculopathy which causes the secondary muscle myositis. And the pathogenesis of, however, the erosive arthritis is not really clear whether it's related to the RF or whether it's related to RNP itself. It's not really clear till date. Genetics, as I told you, it is more related to the HLA-DR4. HLA-DR4 is same as in the RA pathogenesis. Again, this is data from West. We may not have the same phenotype, same haplotype in India. In some studies which are done in India and Asian, actually HLA-DR4 is not associated with RA. So similarly, even Mctd may not be. We have not looked at it. So, however, that tells you that it is something different from lupus and scleroderma. It's not merely an overlap or merely systemic sclerosis with scleroderma, SLE with scleroderma. It has different genetic background to them. So it is probably a different disease. And because it is MHC class 2 driven disease, HLA-DR4 is basically class 2. So it tells you that it is T cell dependent disease rather than class 1, which is innate immunity related diseases. So coming to treatment, there are not much of data as such. The data is actually coming from the different diseases from where the clinical features are, and it is actually lack of randomized trials are there because this patient numbers is not as much to do an randomized controlled trial. So management relies on extrapolation of data from other diseases. So, but one thing is for sure that a lot of patients will need immunosuppressants, and it's not just the steroids which you can manage these patients with. 58% of the patients required aggressive immunosuppression, while only 3% achieve disease control using NSAIDs or short course steroid. So arthritis, your mainstay will be HCQ and methotrexate, similar to the arthritis in lupus or RA. If it's more aggressive, erosive, you'll use methotrexate up front with HCQ. If it is mild, non-erosive, probably hydroxychloroquine will do the trick. However, anti-TNF have also been used in a prospective study of 240 patients, and almost 44 patients in this were erosive arthritis, and all except 2 were treated with TNF plus methotrexate. So this is a combination which may be used. Again, in Indian setting, probably I would use rituximab before TNF, and the cause being tuberculosis risk with anti-TNF, and also the cost, rituximab can be given once in 6 months. The cost has come down drastically, and while TNF still remains every 2 weekly or weekly injections. ILD, MMF is the usual choice of therapy, as in any CTD related ILD, and the dose is around 2 grams. Induction dose is 2 grams to 3 grams, and steroid along with it for 0.5 mg per kg for induction, and slowly come down after a month. Alternatives are used, which are cyclophosphamide and rituximab, but they are used only in resistant or severe cases. And pulmonary hypertension management will follow the same management protocols as in systemic sclerosis, which is dual therapy should be given at least for anyone with WHO class 2 and above disease symptoms. WHO classification is for pulmonary hypertension symptoms, how much you are symptomatic for it. So if you're WHO class 2, 3, 4, you directly go to dual therapy. If you're class 1, grade 1, then you may use a single therapy. Basically, what do you use? Vasodilators like tadalafil, and along with that, you use endothelin receptor antagonist like ambrisentan. So there may be different combinations. This is what is most commonly available, but newer drugs have come out, and things like selexipag are being used as additional drugs. Surgical options are not done usually, but it is only done in very limited number of patients where you have tried all the drugs, it's not working. You can do a septotomy, which will reduce the pulmonary pressures and equalize the pressure on the other side. So evolution, do MCTD, once diagnosed MCTD, are they MCTD for life? So, well, initially when Sharp came out with this 25 patients, they're like, people told him, no, you are actually picking up lupus early, or you are picking up myositis early. Why are you calling them separate? They will just wait for 3 years and they will evolve into something. But actual truth is far from that. So when you followed up patients for almost 8 years, although there was some reduction in the number of patients which were MCTD from beginning to end, almost 50% or 60% of them did not evolve into another disease. 40% do evolve into another disease. So most common of them is systemic sclerosis in 17%, and SLE in 9%, very rarely into RA, the more erosive ones, and some of them were reclassified as undifferentiated connective tissue disorder. So remember, almost 50% or 60% will stay MCTD even at the end. Okay. Prognosis, Lundberg had reported that 1/3 of the patients of the MCTD will have very severe disease, one will have an aggressive but manageable disease, and 1/3 will have very benign disease. So it's not all patients of MCTD are mild, and they are actually having different types. And mortality is around 10%, similar to what is lupus at 10 years, around 10% mortality will be seen, mostly from the pulmonary involvement, pulmonary hypertension involvement. Usually these are the patients who die. So morbidity factors are basically, initially when you have patients coming early, they will have more morbidity related to ulcers, gangrenes that may happen because of Raynaud's, and esophageal dysmotility, which may be causing them symptoms. But later on, it is the damage which causes the issue. For example, the sclerodactyly, the pulmonary hypertension, which has, because vasculopathy has already happened. Nervous system damage may also happen. For example, trigeminal nerve is affected very commonly in MCTD. Is one of the specific features which is not really in the usual criteria that we use, but it has been added in the Japanese criteria now. But it does not respond to immunosuppression. That also you should know. So not all features respond to immunosuppression. Mortality is around 96. The survival in one of the studies was 98% at 5 years, 96 at 10, and 88 at 15. So generally we say survival has been improving, and it's more than 90% at 10 years, similar to what is in lupus, probably a little better. Not the death is related to mortality related to MCTD was only half of the patients, And these patients died of complications of MCT like pulmonary hypertension or progressive ILD. Now coming to undifferentiated connective tissue disorder. So this is what we are talking about, this group where you have clinical features of one of the disease, you have some antibody profile which is positive, but you do not have enough evidence to call them lupus. For example, you see a patient with malar rash, you see a patient having malar rash along with ANA positive, but they don't have dsDNA positive, they don't have complements low, they don't have any leukopenia, anemia, nothing is there, thrombocytopenia. What do you call this patient? There are two ways to go about it. You can call them evolving lupus, or you could call them undifferentiated connective tissue disorder. So when you say evolving lupus, you are like in your mind, yeah, this will evolve. So when do we call that? Usually I would call that if dsDNA was also positive. Some specific serology is positive and the features are very early, less than 3 years. But if it's already been 3 years and above, and your symptoms are only mild and not really confirmatory, then I would call that as undifferentiated connective tissue disorder. So there is a lot of debate on the criteria which should be used, and different rheumatologists may tell you different things, but this is what is generally considered, characterized of presence of clinical features in addition to lab evidence of autoimmunity, but not fulfilling a criteria. It may be evolving disease or a stable Uctd. This was a preliminary classification criteria which was proposed in 1999, still is being used and still being called preliminary criteria, which is that clinical features suggestive of CTD but not hitting criteria, positive serology markers at least on 2 occasions, including a positive ANA. And the third, the duration of illness to be at least 3 years. So this preliminary classification criteria actually excluded the evolving CTDs and rather only included the stable Uctds. So epidemiology, if you walk into a rheumatology clinic with only CTD patients, almost 20 to 50% of the patients will be, the new patients rather, will be Uctd. The true prevalence is however not known because nobody has really looked into this disease, because you cannot do randomized trial in such patients where you, because you don't have a definition which is agreed upon by everyone. But almost 90% of these patients are females with 32 to 44 years, similar to what you will see in probably in lupus. Clinical features, the most common feature is arthralgia in one of the cohorts, 86%, followed by the skin lesions like livedoid rash, purpura, acrocyanosis, urticaria. Raynaud's, sicca are other common symptoms, along with ulcers, arthritis, fever, and thyroid diseases. The antibodies, the most common antibody ANA will be positive, and then Rho and RNP are considered most frequently seen almost in 1/3 of patients each, and rheumatoid factor may be positive. Other tests you do is so many other tests that you can do, but just some of them will be positive, it will not fulfill any criteria. So evolution, almost 50% of these patients remain mild as a Uctd, but the other 20% probably completely remit if you start treatment, and this 30% of these patients will evolve into something else. So that something else may be SLE or rheumatoid most commonly at the end of 5 or 6 years. Survival rate is more than 90% as 10 years. The treatment regimens, again, it is to be individualized and taken from where which symptoms are predominant. If it's lupus-like symptoms, you treat like lupus. If it is myositis-like picture, you treat like myositis, and rheumatoid-like feature, you treat like rheumatoid. So 1/3 of the patient will not need probably immunosuppressive and will manage with HCQ and steroid, but others may need. So these are the further readings that you can do from these topics. So yeah, I see everyone awake. So I think that's nice for me to see that everyone has listened to me, and I will be happy to take any doubts, questions that you want to ask.
Can a disease which is classified as MCTD, because in the original thing you said in that study it evolved then later and became a Uctd. But if it met criteria for MCTD at one point in time, should it be always considered as MCTD?
So not really. You can evolve. That's what I'm. Ideally, an MCTD which has the classification features of puffy hands or Raynaud's finger, Raynaud's should not go ever. And but what in that study, what they have done is they looked at the same criteria they applied again at the end, and then they saw that most of the features have actually resolved or remitted. So that's why they have told as Uctd. But what you are saying, I understand, like once you classify, obviously after treatment, the disease modification will happen. Yeah, probably we should not be telling them Uctd, but in that study, they have done it. But yes, if that evolves into a completely RA phenotype, yes, you should call them RA. Like there is no features of lupus thereafter, and only erosive arthritis continues to be the feature that is driving the disease, then you should call it RA, not MCTD. But that patterns has been explained. Yeah, please.
The human RNP, we have to repeat again and again. Like, is it
Not at all. UNRNP, unlike dsDNA, is not produced by basically short-lived and long-lived plasma cells are there. So when you have long-lived plasma cells, they are basically staying in the bone marrow. And these cells are not depleted by your usual therapy, for example, steroid, MMF, anything for that sake, rituximab also. So these long-lived plasma cells, what antibodies they are producing, it will not become negative. Rarely it can. When you over immunosuppress, it can, but generally it will not change. So if your RNP is positive, it's going to be positive. And also, unlike dsDNA, which has a direct correlation with lupus nephritis, RNP has not been proven beyond doubt to have any correlation with any factors of the disease. It just prognosticates that, okay, if RNP is high titer positive, pulmonary hypertension risk is there. It does not correlate with ILD that much. Yeah.
one more doubt I had was, how many years do we use of this MCTD, depending on the man?
So that answer, I think, for not just for MCTD, for rheumatology as such, there is no answer that. So for us, we tell our patients it's long term. We do not use the term lifelong. We do not use the term short term of 2 months. Usually, once our patients are initiated on DMARDs, they will need one or something or the other. For long term means 10 years and above. There are odd patients, like 1 in 10 patients who are completely, say, asymptomatic and they go off all therapy. Some things which will never completely go is probably the vasoreactivity, because that endothelium is damaged. So they will always have the risk of Raynaud's recurring. So that part usually never goes. Arthritis symptoms may go, myositis may resolve. Pulmonary hypertension, another thing that once it has come, probably you need to treat it. Because if you stop, the pressures will go up probably, unless it is very early disease.
ILD, MMF, you give
ILD, MMF, usually we give 2 to 3 years of therapy and then we reduce it to maintenance. At least 5 to 7 years we keep and then we'll stop. 2 years you have to have full dose. It can't be less than that.
And which one classification do we use in
MCTD most commonly used is Ehlers-Danlos. That is the classification with best sensitivity and specificity.
And one more question, do these antibodies predate clinical?
Yes, as in any other disease, like in rheumatoid arthritis, it can predate the disease by almost 10 years.
So we have to follow them up for clinical.
Yes, so you should not start treatment for anyone who is just antibody positive. So if you have an ANA positive lupus and you do another family related, probably mother or daughter, you have almost 10% chance of antibody being positive in the other person also. So there is a genetic predisposition and then there is a second hit. When the second hit will happen, that's when the autoimmunity will cause the disease. We and everyone, if you check for antibodies, if you check 10 antibodies, 1 antibody is going to probably be positive. What is the ANA prevalence in population? Do you know? Around 10, more than that, 10% and above. So a young person with ANA 1+ not having any pattern, more so older persons, as we age, the antibodies increase in our body, all kinds of antibody, whether it's RF, ANA, anything. So a 60-year-old person will normally have ANA 1+. You don't do anything about it. So you look at clinical features with the antibody and then only decide on treatment. Thank you.
Thank you, Dr. Avanish, for that lecture. And thank you everyone for coming for the lecture. We'll see you next week for the next set of lectures. Thank you.